Welcome to our session on catheter-related bloodstream infection prevention, a comprehensive approach. I want to thank the sponsors, CorMedix, who sponsored this educational program, and for the NKF for inviting us to do this. I just want a bit of housekeeping. Please get your evaluations done at the end of this to be able to get your credits. So the agenda today, I am going to talk about patient-level strategies to prevent catheter-related bloodstream infections. My name is Charmaine Locke. I'm a professor of medicine at the University of Toronto and a nephrologist at the University Health Network. I was also the chair of the KDOKI Vascular Access Guidelines. And I'm very lucky to be able to work here with Julie White-Nunez. She is a prior career in systems engineer, and now she is a practicing nephrologist at the University of Michigan, Ann Arbor. She leads a research platform focused on optimizing patient-provider communication in kidney disease, primary kidney disease prevention, CQI, and health systems optimization. She is the medical director of the Tobin Ambulatory Care Unit, and she provides outpatient care across 5 internal medicine subspecialties, encompassing 35,000 outpatient visits yearly. So she's very busy. And she's also the Department of Medicine's Associate Vice Chair of Quality and Innovation, leading a team of systems and engineering specialists to optimize care and quality across 13 divisions of medicine. So I'm extremely excited to hear her talk on systems-level strategies to optimize prevention of catheter-related bloodstream infections, opportunities using continuous quality improvement methods. So the learning objectives of this educational program is to recognize patient-level strategies to prevent catheter-related bloodstream infections in patients receiving hemodialysis, and to identify systems-level strategies to evaluate and optimize infection prevention strategies, including the utilization of quality improvement. And so with that, I'm going to start my presentation, and again, thank the NKF for the opportunity to be able to present patient-level strategies for preventing catheter-related bloodstream infections. These are my disclosures. And my objectives are, I'm going to discuss recommendations for appropriate hemodialysis vascular access really briefly, fistula, graft, or catheter use per the KDOKI guidelines. And I'm going to discuss important clinical aspects of catheter-related bloodstream infections, what it is, how it's defined, the risks of CRBSI in patients receiving hemodialysis, and how to prevent it. So what do the KDOKI vascular access guidelines say, the individual steps for CRB prevention, and the targeted options to lower CRB risk. And throughout this presentation, and I'm sure Dr. Wright will as well, really highlight the importance of patient education and shared decision-making. So I guess when you're thinking about catheter-related bloodstream infections and catheters, the easiest thing would be to say, isn't it simple? Let's just avoid the catheter. If we can avoid the catheter, we're going to avoid complications. And the key complications, of course, are catheter dysfunction and infection. But for everybody here in the room, and I'm a dialysis physician, there is a reality. And the reality really is that all vascular accesses actually have complications. And these look quite dramatic, but this is what we do see, actually. There's lots of complications that actually happen in AV fistula, AV grafts, as well as central venous catheters. And so with that, I think it's really not that simple. And the prior messages that we used to have been updated. So as we all know, it's no longer fistula first, and we've lived through that fistula first era. And it's also not all catheters last. So what does the KDOKI vascular access guidelines say? They say get the right access in the right patient at the right time for the right reasons. And there's a lot behind that, and we certainly don't have time to talk about how do we choose the right access and how do we do it, but that is the new mantra. So given that there are complications for all access types, who should really get a catheter? And these are 2 of my patients. The one on the left, he is actually a 93-year-old gentleman, and when I met him, he was 90 years old, and he came from another dialysis unit, and of course the first thing I say is, sir, really we should think about removing your catheter and getting an AV access. And he looks at me and he goes, Missy, I got this in when I was 77, and the interventional radiologist said, when I put this in, I have to tell you about the risks, and you're going to have a high risk of getting an infection, and you're going to get sick, and you're going to go in the ICU. And he said, I told the radiologist, I don't care. He said, I don't want to have my arms needled. And when I met him, he had that single catheter, and this is true, for 13 years. Yeah, the same catheter. And it was under my watch, unfortunately, that there was a crack and we had to change it. And he continued to live with that catheter. And he used a catheter for over 16 years before he passed away from something completely different, nothing related to vascular access. On the other hand, we see this gentleman here. He's a younger man, very healthy. He's actually exercising, doing his bicycling on hemodialysis, and he has a kidney transplant that's due in 1 month. So, he doesn't have an AV access created, and I think it's very appropriate in that situation to continue on with a central venous catheter. So there are valid short-term uses for central venous catheters. They include having an AV fistula and AV graft that's not ready to be used, so they're not mature yet. If you have a kidney transplant and it's rejecting or there's some other acute complication, yet you still need to be supported with dialysis. If there's a peritoneal dialysis complication, Jeff, I know they do occur, and they need a time-limited peritoneal membrane rest or an equivalent, or if they have a pleural leak and they need some support, or the patient has a living donor transplant with a confirmed operation date. And I think that's really critical because we see all of these patients who say, oh yeah, I have a living donor, and 5 years later, they're still on dialysis without having that kidney transplant. Also, if you have a fistula or graft that has a complication, so we've all seen those major infiltration injuries where you really need to rest that arm, and in the meantime, it's very valid to have that temporary central venous catheter. And in some, limited special circumstances, it's okay to have a temporary non-tunneled catheter for a limited time period. And there's also valid long-term uses of a central venous catheter. So some patients have no other access type available because they've already failed everything else. And so the only option is a central venous catheter. They may have a limited life expectancy. They may have no options for AV access creation because of limited or suboptimal anatomy. And patient preferences, so that gentleman that I talked to you about, after having informed consent and really telling the patient about the risks and benefits of using a central venous catheter. And then, of course, there's special medical circumstances. And so this is the great Dr. Robert Uldall, who created the dual lumen catheter at the Toronto Western Hospital. And he was the gentleman that really allowed us to have the use of central venous catheters as a permanent option. And he said, if any complication can be anticipated or imagined, somewhere at some time it has happened. And at the time, we used subclavian cannulation. And he said subclavian cannulation for hemodialysis is a privilege. We have an obligation to make it safe. And so, the complications that we have include catheter dysfunction and catheter infection, and we really need to make sure we're providing safe care for our patients. And the pathophysiology underneath it includes, thrombus, biofilm, and fibrin sheaths, and they're all interrelated with regards to dysfunction and infection. But for the purposes of this talk, we're going to really focus on catheter infection. And so there's 3 types of catheter infections, as you all know: exit site infections, tunnel infections, and catheter-related bloodstream infections, or CRB for short. And exit site infections and tunnel infections can, move into each other and also be associated with catheter-related bloodstream infections. So how do we define it? So this figure is from the KDOQI guidelines. And you can see next to it are the prior guideline definitions, the CDC and the IDSA. And I actually really like the updated KDOQI guidelines definition because it actually incorporates the CDC and the IDSA definitions, but it's actually quite simple. So to define catheter-related bloodstream infection, you have to have a clinical manifestation. So as you know, your fever, your hemodynamic instability, so on and so forth. And you need to have a positive blood culture from a peripheral site. So typically we used to think of a peripheral site as the peripheral vein, but now we can actually use the dialysis circuit as the peripheral site. So you need to have a peripheral site and a segment from the catheter. You don't need to take the catheter out to get the tip. What's the point of doing that to make a diagnosis? You can actually use the hub. So if your peripheral site, let's say your dialysis circuit and your catheter hub have the same organism and there's clinical manifestations, then you have a catheter-related bloodstream infection. So it's a very clinical definition, very practical. You don't need to do venipuncture, which is great because you can save the veins and you reduce contamination. So that is how you define catheter-related bloodstream infections. And why is it important? Why are infections important in hemodialysis? Well, it's the most common cause of morbidity. It's the second most common cause of death. The majority of infectious deaths are due to bacteremia. And vascular access is the main source of bacteremia. And we know that out of all of the access types, that catheters are the vascular access type associated with the highest risks. And these risks have ranged over time in the literature from 0.5 to 6.5 per thousand catheter days. Our rates are coming down in some centers, going up in other centers, but that's the basic range. And on average, the cost is about $22,000 US and can be as high as 33 to 35 if you have an ICU stay. So very, very expensive. And the important thing about infections in hemodialysis is that it can be prevented. So what are some of the risk factors for catheter-related bacteremias? Well, the catheter site maybe, where it's placed, femoral versus IJ versus subclavian, and we're going to see in a minute how true this is. The catheter characteristics, if it's non-cuffed versus cuffed, non-tunneled versus tunneled. If you have a catheter in longer, then you're going to have greater exposure and risk for infection. If you have thrombosis of the catheter, and we'll talk later with regards to the pathophysiology why this might be. If the patient is in what I call a stress state, so if they've had recent surgery, if they have diabetes, or if they're immunocompromised, and I submit to you that any patient on hemodialysis I consider relatively immunocompromised. If the patient has poor hygiene, and if they've had a previous bacteremia. So let's just take a look at the data. You know, if you had to have a central venous catheter in a patient, where should it go? The number one place is the right internal jugular because of its anatomy. It's more direct anatomy. But the KDOQI guidelines say if one side has pathology that limits AV access creation but allows the catheter to be inserted, use that side because you want to preserve the other side for AV access creation. Next is external jugular, femoral, subclavian, and then lumbar. And I can tell you the work group actually had quite a bit of a debate about that order. And then the type of catheter, if it's tunneled versus non-tunneled, and then the design. So does the catheter location impact infection risk, and does the catheter type impact infection risk? So I'll say right now that yes, tunneled and cuffed versus non-tunneled makes a difference. So non-tunneled, non-cuffed have about 3 to 5 times greater risk of infection than the tunneled cuffed. And really the design really doesn't have that much difference. But what about location? And I'm sharing this because I really want to emphasize that we need to have evidence before we make decisions. So this was an older study, but a very important one. It was a randomized clinical trial looking at femoral versus IJ catheterization. And everybody thinks that a femoral catheter is associated with greater risk of infection. This was actually quite a significantly large number of patients, of 750 patients that were randomized. And they actually found that there was increased mechanical complications in the IJ versus femoral catheters. So thrombosis of 3.6% in the IJ versus 1.1% in the femoral, and that there was no difference in infection. And in fact, the bacteremia rate was slightly higher in the IJ of 2.3 per thousand days versus 1.5 per thousand days. And that kind of goes against our instinct where we think that, you know, in the femoral site, you're going to have an increased risk of infection. And this was supported further by a Cochrane review and a meta-analysis. So I guess my point with this is, you know, we really need to try to use data to inform clinical decision-making regarding risks in patient education, and including for prevention of catheter-related bloodstream infections. So how do we prevent these infections? And I think the best way to prevent it is by using a targeted approach. And when I say targeted approach, I mean understanding what the pathophysiology is and trying to prevent it based on that. So what is the pathogenesis of catheter-related bloodstream infection? So we know that the majority of organisms are gram-positive organisms, followed by gram-negative organisms, with mixed organisms and a smaller percentage that is fungal. And for gram-positive organisms, the majority are Staph aureus that we see in the nose. So about a third of us are Staph aureus nasal carriers, about a third are intermittent carriers, and a third of us don't carry Staph aureus in our nares. And then we have Staph epi on our skin. Everybody has it all on our skin. So those are the key organisms. But the key thing is, how do those organisms get onto the catheter? And so there's two routes of entry: the extraluminal route and an intraluminal route. And we also want to look at the duration time frame of when that catheter is inserted to when you might get these infections. And the extraluminal one tends to occur early, before the exit site is healed and the intracutaneous tunnel has been formed. Whereas the touch contamination, the intraluminal, actually can occur at any time. The only reason why we say it's referred later is because the extraluminal one tends to predominate in the early period. The key thing is that bacterial attachment. It doesn't matter if it's extraluminal or intraluminal. The common final pathway is that bacterial attachment to the catheter, and that's really what we want to avoid. And why do we want to avoid that? It's because that's how biofilm forms. So you can see those little spears, they represent bacteria. They actually have flagellae and motile appendages. But once they land on that catheter, everything shuts off. They become sessile. They gather together and they start communicating. They have cell-to-cell signaling. They pull out their cell phones and say, hey guys, let's get together. And really they reproduce, and they start making this glycomatrix, this polysaccharide matrix that is a protective shield. And within that protective shield, they reproduce, they change their characteristics, and they can actually fly off to other areas of the body and cause problems. And when you have a biofilm, it takes about 25 to 100 times the concentration of antibiotics to break through it to actually treat the bacteria. So this is what you want to avoid, because once it attaches, all of that cell signaling and that whole cascade occurs. And then I wanted to introduce that, thrombus may have a role in this because it acts as a nidus of this infection and gets incorporated into the biofilm. So let's talk about the extraluminal route and how we can avoid that attachment. So what happens is, you can see a patient is here, you can see his skin where the exit site is. All of us, many times we touch our face. Patients are uremic, they have pruritus, they're scratching their face, they scratch their chest. So it's very easy to transfer Staph aureus from other parts of their body onto the chest. You can see there's a coat there that may touch the patient's skin. So bacteria is on the skin surface. Before the exit site is healed, the bacteria enter through the exit site along the intracutaneous tunnel, along the outside of the catheter to the tip, and then it gets dispersed, and that's how you get catheter-related bacteremia. So it's often skin contamination. And you can see here in this patient with the femoral catheter, and it's hard to speculate why there's less infection in the femoral if you are handling it properly. It could just be because of the upper extremity, you have more movement taking your clothes on and off, whereas if you have a femoral catheter, it's probably in the pant and not a lot is done. It's really hard to know why that is the case, but skin contamination is the major route of extraluminal infection. So what do the KDOQI guidelines say? The KDOQI guidelines really say you need to have a good catheter care protocol for exit site and hub care to reduce this. And in the guidelines, there's actually templates on how you could do this. You want to cleanse the catheter hub when connecting and disconnecting with chlorhexidine. And if there's an allergy, you should use povidone iodine. And you want to cleanse the skin surrounding the catheter exit site with chlorhexidine, and again, if allergic, to use povidone. And this is something that we teach all of our home peritoneal dialysis, hemodialysis patients, as well as their caregivers. It's really important to have really excellent CVC management, not just the patient, but to make sure that that technician and nurse does this properly. So use of a mannequin to have training sessions to make sure that they're gloved and masked. the patient is masked and has their head turned away because they're often wanting to talk to the clinician when the catheter is being manipulated. And practice on a mannequin, make sure that you're doing it properly. So how can we actually prevent it aside from good catheter care? So the KDOQI guidelines say that it's reasonable to use topical antiseptic or an antibiotic barrier because you're providing that barrier at the exit site in addition to cleaning at the exit site. It also says, you don't have to change the dressing every single time, particularly when a new catheter goes in, because even though the intention is to clean it, you're actually disrupting the skin around it and the flora that's there, often introducing that bacteria into the exit site before it's healed. So in our unit, we only change the dressing once a week unless, it's indicated if it's come off or it's become dirty. So you don't have to manipulate excessively. So you want to protect the dressings from wet and dirty environments, and there's a real debate whether or not you should shower. And really, we advise patients not to shower until the exit site is healed and to make sure if they are to properly cover it. So what can we use? So there are randomized controlled trials looking at topical agents. So the first clinical trial that was done was by Adair Levin, who used providing iodine at the exit site of subclavian catheters and demonstrated that it reduced exit site infections and bloodstream infections. There was then a study looking at mupirocin versus placebo by a number of authors that showed a reduction in bacteremia, but it also showed that it could actually eat away into the catheter material. So there was another study looking at Medihoney, which is expensive, and you have to get a certain type from New Zealand, and it demonstrated equivalent reduction in bacteremia as mupirocin. And then we did a study using polysporin triple at the exit site, and you can see the figure next to it. We actually showed that by reducing bacteremia, we're able to reduce mortality in patients with bacteremias. And then we also showed that we can continue this through a long-term study. And recently there was a study looking at Tegaderm CHG dressings, which also improved catheter-related infection rates in hemodialysis patients. And this is just the polysporin triple study that demonstrated a reduction in bacteremias, catheter removals, and hospitalizations. So now let's focus on the intraluminal route. So when do you get intraluminal exposure? Well, I say any time that you manipulate the catheter. So the intraluminal route of bacterial entry is when you have tetra hub contamination, and is probably the most frequent route for hemodialysis catheters. Other types of infections are
Hematologic. There we go.
Oh my God, you can say it. I'm really jet lagged. I just came from somewhere else.
No, it's totally
Hematogenous seeding. So if you have a gallbladder infection or pneumonia and it seeds it, or infected infusate, which is quite rare because we don't do that for most of our dialysis patients. But you can see in this figure that there is a technician or a nurse that is manipulating the catheter, and the cap is off, right? And I have actually seen in our unit a cap that has fallen. The nurse looks at it and says, "Is anyone looking?" Case 7-second rule, and puts it on. And I just say, it is not a cookie. You cannot do that, right? So no, you cannot do that at all. The other thing that is, that happens is, this is the key time that the patients can talk to their clinicians when they're manipulating the catheter. And this is when the bargaining happens. I only want to stay on dialysis for 3 hours. I don't want to stay for 4 hours. And the nurse says, no, you have to. I don't want to have, 3 liters removed. I only want 1. And then they start fighting. And then they get passionate. And then they start spitting. And there's all of this stuff in the air, right? And that's how that lumen gets contaminated. There's many, many reasons. Or the nurse has to get called somewhere else, picks up a pen, forgets that they're touching something else, and then goes and puts the cap back on. So these are human nature things that happen. So it is very, very frequent. And that is how this happens. And so we need to really prevent that. So we need to prevent what's happening inside the catheter to prevent infection. So this study looked at thrombus reduction and how it may actually affect intraluminal infection. This was a study that was published in the New England Journal of Medicine called the Preclot study. And what we did here was we randomized patients to heparin 3 times a week or TPA in the mid-week intradialytic capping period. And what they found was that when you use TPA, yes, it did actually reduce malfunction, as you can see here the time at the bottom with the TPA. But what they found secondarily was it actually also reduced bacteremia, which makes me think that that thrombus acts as a nidus of infection. So if you can reduce that thrombus, you may be able to reduce that nidus of infection. The KDOQI guidelines say that you can use the selective use of specific antibiotic locks for patients who are at high risk to reduce infection, so for prevention. And there were a number of agents that were chosen through the evidence review team, cefotaxime, gentamicin, and cotrimoxazole. But they also say that they can't support it on a routine basis because they don't want to have resistance for antibiotics. They looked at antimicrobial locks, and in patients with high risk or high rates of infection, that antimicrobial locks also could be used for prophylaxis. And again, they didn't want to support it because there really was a lack of strong evidence. They did support the use of TPA based on that New England Journal of Medicine study, and particularly in patients with multiple catheter-related bloodstream infections, because that's a high risk factor in nasal carriers. This was the evidence that KDOQI used to come up with that information. But since that time, there have been new studies. And so I just want to share 2 new studies that I think are really important. And this was just published right before the KDOQI guidelines came out, and we were not able to incorporate it. This was a cluster randomized trial of ClearGuard versus the Tego and Kuros cap by Steve Bernelli. And what he demonstrated was that you can actually focus and target on the intraluminal source of infection using ClearGuard as well as the Tego and Kuros to see, can we reduce infection? And what they found was that in all of their different types of analysis, that ClearGuard was actually very effective in reducing catheter-related bloodstream infection by targeting that intraluminal cause of organism attachment. And so they found that it was very positive, and unfortunately the guidelines were not able to publish this. But there's also a new locking agent called DefenCath, which is troledine heparin. And what is it? It's troledine 13.5 milligrams per milliliter and heparin 1,000 units per milliliter. And troledine is actually both antibacterial and antifungal, and what I like about it is it doesn't cause resistance. So the mechanism of action is that it's derived from an amino acid taurine, and in the metabolism of troledine to taurinomide, it actually liberates these methyl groups that react to murines in the bacterial cell wall. It also has hydroxyl groups and attaches to the hydroxyl groups of endotoxins and exotoxins, and this activity inhibits that formation of the biofilm, which I really focused on as a critical factor for catheter-related bloodstream infections. And there was a large systematic review and meta-analysis that looked at troledine as a locking solution to prevent catheter-related bloodstream infections. And they looked at over 1,200 hemodialysis patients with TPN and oncology patients, and found the pooled incidence rate ratio to be about 0.3, so very impressive. And to prevent catheter-related bloodstream infections. However, they cautioned that the evidence was limited due to a high risk of bias, and that they suggested that a large-scale randomized controlled trial was needed. And so with that, there was a large randomized controlled trial, which is called the Lockett 100 study. It was a multi-center double-blinded randomized controlled study of 70 sites, including 150 dialysis units. They included adult hemodialysis patients that had to have had a minimum of 2 times a week hemodialysis and using tunneled central venous catheters of greater than 2 weeks to be enrolled. There were a number of exclusion criteria, but the key ones were they needed to not have antibiotics within 14 days of enrollment. They could not have TPA use within 30 days due to the pathology that I explained, and they could not be under systemic immunosuppression less than 6 months. So these were it ties into the risk factors that I talked about. And the primary outcome was time to catheter-related bloodstream infection. In the middle of the study, they found that, most patients ended up in the eMERGE or in the hospital to have that diagnosis rather than in the clinic. So the definition was changed along with the FDA. And what they found was, and this was a large study, you can see that there was almost 400 patients in each group, which is quite significant for a hemodialysis study. They found that the catheter-related bloodstream infection was significantly lower with the DefenCath group versus the heparin group. And you can see that it's very statistically significant with a hazard ratio of 0.29. And so you can see that the bacteremia-free survival is significantly better in the taurolidine group in blue compared to the heparin group in red. The authors also did a number of subgroup analysis looking at age, race, sex, time since dialysis start, age of the catheter, and location of the catheter, and found that all of them, except for the catheter location, favored taurolidine heparin use, or the DefenCath. The only thing that wasn't found to be significantly favorable was the location, and just to point out that the femoral location was only in 8 patients, and you can see the wide confidence intervals. So with that, I think we can target the intraluminal source of bacteria attachment by using intraluminal catheter locking solutions. So my final suggestion from the KDOQI guidelines is that they really recommend including an infection surveillance program to monitor and track infections to help prevent and evaluate outcomes of vascular access infections, particularly central venous catheters. And, by preventing catheter-related bloodstream infections, it really will help achieve the KDOQI goal to achieve reliable functioning, complication-free dialysis access, so not having infections, to provide prescribed dialysis and preserve our future dialysis access options in an individual patient's end-stage kidney disease life plan, to be able to get the right access in the right patient at the right time for the right reasons. And so to summarize, I think central venous catheter infection can be prevented by focusing on strategies that target the pathophysiology. So consider the extraluminal and intraluminal routes of organism entry, so you can make sure we have good connect and disconnect protocols, barrier ointments, locking solutions, and novel caps. And Dr. Wright will talk about surveillance programs and infection control teams. And throughout all of this, we certainly need to engage our patients and educate them. And with that, I thank you for your attention.
Thank you so much, Dr. Locke, for that wonderful, wonderful talk and review. Okay. So where's the next one?
I think it's...
Do I go back to sessions?
Yeah, I think it's... Jim, how do you
go back to sessions? Okay, sorry. Technical difficulties. Okay, here we go. System level strategies.
Okay, but you have to make it into presentation. How does she make it into presentation?
Present now?
Yes, present now.
Success. All right. So yes, my name is Julie Wright Nunes. I am a kidney doctor. I work at the University of Michigan. Thank you so much to the NKF for inviting me to do this presentation, and all of you for hanging on until the end of the day. I really appreciate it. So these are my disclosures. And we already touched on the learning objective. Thank you, Dr. Locke, for that. So I'll go into the outline. So we're going to shift gears. We're going to talk about a related topic, but something that's very different from what Dr. Locke was talking about. I'll very briefly touch on the importance of preventing catheter-related bloodstream infections, which I thank you, Dr. Locke, for really going over so well. Then we're going to touch on systems and continuous quality improvement strategies that are used or have been used to prevent catheter-related bloodstream infections. We'll talk about national approaches that have been used and what evidence shows through 2 systematic reviews that have been done looking at this very topic. So first, why is prevention so important? Well, one reason is because a high proportion of patients use a catheter to start with hemodialysis and oftentimes chronically later on. So use of these catheters, as has been explained, is a significant associated risk factor for infection. And although there can be lots of other reasons for infection in this very immunocompromised population, catheters is certainly one of the higher risks associated with it. It also is associated, as we get infections, with other bad things. The spread of infection to other areas, high costs, and associated morbidity and mortality in our patients who already are suffering from a lot of conditions. So the reason why systems and quality improvement strategies can help us is because by using these methods, we can avoid pitfalls that stop us from truly solving the problem we want to solve. So 3 common pitfalls are listed here, and they all deal with making assumptions. Assuming we know what the problem is without actually observing what's happening, assuming we know what's causing a problem, assuming we know how to fix it because we know what the cause is when we actually don't. So getting from the problem to the solution with making assumptions is something that systems and quality improvement strategies can help us address. I just wanted to review a few definitions of terms that we might hear when we talk about systems and quality improvement. What is it? It's kind of nebulous. These are 3 terms, and I don't want anybody memorizing this. It's more to understand that we might hear different terms and where does all of this fit together. So systems engineering is looking at more of the big picture of complex systems. Systems improvement is getting into the nitty-gritty, looking at performance, efficiency, and quality of trying to improve. And then continuous quality improvement is using standardized methods to identify problems, analyze them, and fix them for better outcomes. The continuous quality improvement kind of philosophy, it really focuses on continuous. So what does that mean? Cyclic processes. It doesn't mean we're going around in circles trying to fix problems and not getting there. It means that once we put in interventions, we're checking to see if they work, and if they don't work, we're adjusting them to do a little bit better. It focuses on multidisciplinary teams, not personalizing to one individual, but looking at the entire system or processes to change or improve something. And just a word, again, we're talking just a little bit about verbiage, the difference between quality assurance and quality improvement. So quality assurance is more about looking for things that happen, oftentimes bad things, and tracking them, inspecting for these events that we call them, and then measuring how we're doing against them. And continuous quality improvement is really more about improving processes to meet standards, being proactive, not looking at one person or one part of a process, but looking at a whole system. These are both okay, and I kind of use them interchangeably, and I'll talk about how they've been used interchangeably, but just important to know that they're different things. So I'm going to come up with a polling question. It's just about whether or not you've applied systems and or continuous quality improvement methods to preventing bloodstream infections. So if you take a picture, if you want, it's the end of the day, but if you take a photo of that, you can tell me if, 100%, oh, okay, well, I was getting excited. So now we have 2 people answering, so now we're 50-50. So for people who are answering yes, wonderful. Some of the things that I'll be talking about may be review for you or just add to what you've already been doing. For people who aren't sure, because they're not sure maybe what some of these things I'm talking about mean or aren't sure how we're defining them, or people who just say no, all of that's okay too because you're in the right session. So to go through all of the different tools and methodologies and strategies here would take years. It's called an engineering degree in industrial engineering, but I'm going to highlight just a couple tools that I often use within medicine and within the teams that I lead that have really helped me. And again, it may be review for some of you or news. So either way, okay. So the first is called a PDCA process. PDCA is an acronym. We love our acronyms, right? CKD, ESKD. Sometimes it's called PDSA. So what it stands for is plan, which is identifying the problem and really getting in there to analyze a current situation to know what the problem is. Then doing, which is testing solutions for process changes, checking or studying the results to see that we're getting out of it what we want, and then redesigning a process to fit best into the interventions or disseminating it. So this might look a little boring, and we might be saying, well, why are we talking about this acronym? But this is a really powerful tool, and it's brilliant in its simplicity. electricity. It was developed in the early 1900s by a physicist, and it was applied to basically disseminate out our whole telephone system in the early 1920s and 30s. It was also used to basically save Japan after World War II. It was brought by an engineer called Demings to Japan when they were basically decimated after World War II. And using this principle along with other continuous quality improvement principles, they became a manufacturing leader in cars and other areas, and it's still used today. So again, it looks a little bit like maybe boring or snoozy, but I'll tell you, when it's applied systematically, it works. Another favorite tool of mine is called the A3. So A3 is a size of paper, and the dimensions are shown here. Long story short, it's a big piece of paper. So it gets its name from the size of the paper. But what it is a working document. It's a working document that we use to fix a problem. And it's used by dividing the paper into sections that basically force us to address certain areas of solving problems. Understanding the background or the ugly story, assessing our current situation, creating a goal of what we want to improve, doing analysis and implementing recommendations, along with a plan and follow-up. So it's all done on this piece of paper. It's usually using multidisciplinary teams. It doesn't have to be paper, it can be electronic, but I'm telling you, when you use it with large teams, it's a great visual. You can mark on it, you can see where you've been, what you've been doing, and it's kind of a great tracking and consensus building type of tool. I just wanted to mention that the goal part of this, inside the part that says goal, kind of on the left-hand side, it's really important that we have goals, right? It's really hard to get to some place if we don't have a goal of getting there. And this SMART acronym, again, another acronym that we love called SMART, again, stands for specific. Make that goal specific, measurable, achievable, and relevant, meaning it matters clinically to you, and it's time-bound. It's not something that we're just going to do. We're going to actually make, by October, we want this much improved in this area. A colleague of mine that I work with, Dr. Michael Hong, likes to always point out that the A3s are kind of something we're doing clinically already every day when we do a history and physical. So when we're talking to our patients, we're getting the background, we're doing an exam, we're making impressions, we're making plans, and then we have follow-up. So that A3 is just doing the same thing in an organizational process manner. So there's a whole bunch of continuous quality improvement and systems improvement methods. I'm not going to cover them all here because we want to move on to other things. But what I did is I did put them in the slide deck. One's called process mapping, where we can map out processes for efficiency. Going to the Gemba means going to the place where work is done to see what's actually happening. And terms that you might often hear is root cause analysis. So you can kind of think of like the weed as the problem. And the roots below it are all of the causes to the problem. And we want to get at those causes. We want to break that problem down into smaller chunks so that we can fix it. And what people use as far as tools to do that is called fishbone diagrams, cause-effect models, or Ishikawa diagrams. Ishikawa was the person who developed this. So this is something that you'll be able to refer back to, along with another whole host of continuous quality improvement tools that I listed here that I'm not going to go through in detail. The one thing that I did want to mention, though, is one of my last favorite tools. It's called an impact effort matrix. I didn't learn about this until I went to the University of Michigan, and my systems engineers told me about it. So this is once we get to solutions. Once we get to a list of solutions and we're not quite sure which potential solution we want to test or try out. What the impact effort matrix is along the y-axis you have how much of an impact to the problem you think that this might achieve. And then on the x-axis we can see, well, it takes a lot to put this in on the right, or do the solution on the left. It's not a bunch of effort. And so what you do is you take the list of solutions and you kind of categorize them in these different quadrants. And what we do is we focus on that top left quadrant as those quick wins or things that we'd prioritize to do for solutions that we're trying in these PDCA cycles or otherwise. So just a little tip. So now we're going to move into what have been national approaches in systems and quality improvement. And we already kind of touched on the National Kidney Foundation, KDOQI guidelines and so forth, but I think that this is one of many kind of national organizational examples of us trying to standardize definitions and standardize work and create processes that we can all use. It doesn't mean that we can't tailor it a little bit to what our needs are, but these KDOQI guidelines I think are a really great example of standardizing definitions, as Dr. Locke pointed out, related to what even is a catheter-related bloodstream infection. And then creating guidelines that to me are like a process flow map, algorithms for treatment, whether it's inside the lumen or outside of the lumen. And I put here as well, I'm sure many of us already have this information, but a URL link that you can reference. And there's tons of great information to download, patient-facing, clinician-facing, even things you can use in the centers. Another thing I wanted to just mention is a historical perspective of something called Fistula First, and again, it was already mentioned. But I think that this is a good example of a system, United States system-wide attempt to improve an area. In this case, a percentage or proportion of people who were using fistulas, in part to reduce the catheters or the related bloodstream infection that might be associated. I'll talk a little bit more about that later, but the goal was to increase the fistulas, and it was launched in the early 2000s with something called a Fistula First Change Package. It was 11 steps of quality improvement tools, establishing relationships with surgeons and patients and multidisciplinary teams to basically improve access. And it worked. We did improve the proportion of fistulas throughout the US. We saw some other issues after that, so that's kind of an aside. And now we've moved into more of an era of like the end-stage kidney disease life plan. A patient life plan first. Where are you at? I mean, if somebody's maybe at terminal stages or elderly or have tiny vessels or tons of comorbidities, maybe surgery, even if it's a little one, isn't the best for them. So, but I think that this is an example of an earlier model of trying to improve things in a systemic fashion. So now we'll get into some other things put on by the CDC and other organizations. Many of these are super collaborative efforts. I love the work that the CDC has done with others to create resources that are available for education, downloadable tools, posters that are multilingual, tracking forms, and of course the core interventions that are recommended. And this is for preventing all types of bloodstream infections, but there's 9 steps that again suggest ways for surveillance, emphasizing hygiene, hand hygiene and observation collectively to implement to try to reduce bloodstream infections. And I put the link down again so you can take a picture or you'll have it in your slides. The other thing is other helpful links that it links to the National Healthcare Safety Network, which I think of as a way for facilities, states, regions, and the nation to share data. We put in their events, including related to infection, and then we can compare and maybe see where people are doing great work, maybe lower rates versus other, and learn from each other. There's also videos and tip sheets, and these are just a couple of them, again, collaborating with other groups. One other collaborative approach that I wanted to highlight is called Project First Line. So it's a collaborative with a lot of other organizations, but CDC and AMA. I actually went to this webinar. So they put on webinars. These webinars are recorded, then they're transcribed. So you don't even have to attend the webinar. You can just read it afterwards. They have multidisciplinary teams talking about the very topics that we're talking about here. And this is one of the webinars called Decreasing the Risk of Dialysis-Related Infections. Again, I put the URL here for you to reference to or look up. But I wanted to share with you some tips that I thought were fantastic, that are systems, quality improvement, a little bit assurance, but I thought that they were highly relevant. One of them is the use of something called huddle boards, posting patients who have catheters for a daily focus. We all have different levels of quality meetings, whether it's a weekly check-in or a monthly check-in, but what this does is puts it right in your face every day as something to focus on. All of the people in this particular webinar I attended talked about protocols getting switched over to AV fistulas. And I think we can probably agree or just even share ideas that a lot of us have these same protocols. What I thought was really great is that one of the social workers was talking about doing reminder phone calls for the appointments to get fistulas. We have reminder phone calls at Michigan. I mean, that's not so rocket science, but it wasn't really a reminder about the appointment. It was actually to encourage people and say, hey, how are you feeling? What are your concerns with this? And they actually saw an increase in people following through. It's scary for me when I go to appointments, and the point at which the portal sends me a text message to cancel some scary appointment, man, my finger's right on that button wanting to cancel. So this is just a way to maybe get around that. They all emphasized interdisciplinary teams, early education for the right access, starting in primary care, which I think is fantastic. And then again, as we've talked about, really focusing on the right access, person-centeredness at the right time. So maybe an AV fistula is not exactly the best access for a certain individual. Also collaborations with Making Dialysis Safer for Patients Coalition, which aims to prevent bloodstream infections in patients on dialysis. And people can get involved, you can sign up to be a part of this, and you can access all these great tools. Again, you can use them at your centers, print them off. I'm not part of this coalition, and the URL for that is listed. Okay. So we've covered a whole bunch, and now we're going to move into, well, what does the evidence show? And I'm going to review 2 systematic reviews that are talking about the evidence that's been published using systems and quality improvement strategies, and what have the outcomes been, and has it impacted outcomes related to infection. One caveat I want to make, which is a big limitation that you and I both know, and that is that I don't really publish all of the stuff that I do in quality improvement where I work. As a matter of fact, a lot of the stuff that I do, we just kind of keep working in our jobs and we cheer each other on and then we move forward. In the role that I have right now, one of the roles in my job is leading a team of systems engineers, and it's helping the divisions in our department improve areas of quality. And now I've started to incorporate ways to translate that into scholarly work and reporting, not to get publications, but to share what we're doing with the rest of the world. If anybody wants to talk about that, I'm happy to afterwards, because we've done some things that have increased our scholarly work and publications by about 300% related to what we're doing. So this is one review that we did, and we were really looking for how has quality improvement been applied within nephrology. And so it wasn't just focused on catheter-related bloodstream infections, and I'm going to summarize it in about 30 seconds. We looked at 76 studies. 8 of them were related to catheters in general, and none of them were specifically focused on bloodstream infections. They were focused on simulating catheter insertion, increasing AVF, so that's peripherally related, as we've talked about, and then just reporting on processes for education and indicators. The methods used were some of the ones that I talked about: root cause analysis, standardizing work and protocols, multidisciplinary teams, something called Donabedian assessment, which is looking at structure, function, and process to solve problems, and a Delphi technique, which is used as basically a way to gather consensus about something, getting a lot of input sequentially. So that's it about that review. So not a lot there. There's been another systematic review since, done in 2023, led by Dr. Benjamin Lazarus. I actually spoke with him last week. Thank you to that man. He's in Australia, and he was on the phone with me at 10 o'clock at night just because I had some questions and wanted to prepare this for you. So I made sure what he had done, and I understood it all correctly. So thank you to him and his team. But what he did is he led a study, again, a systematic review to determine whether the implementation of systems and quality improvement can prevent hemodialysis catheter-related bloodstream infections in patients outside the ICU, comparing with usual care. And they also wanted to identify common themes, like what were the tools that you all used that helped? And it had to include more than one approach in quality and improvement, so 2+ approaches. Really, I think trying to show a commitment that the system had, or the center had, to systems and QI improvement on a larger scale. So I highlighted in yellow the common themes that he found. One, that when these QI and systems implementations were done, pretty much all of them used surveillance, so more quality assurance of bloodstream infections to measure effectiveness, but they did measure, so part of that PDCA cycle. They referenced standard protocols and made processes, so some of the process mapping and the protocol development. Everybody assessed outcome and process measures to inform future changes, so the cyclic cycles that I talked about. They did describe a variety of leadership structures, but leadership always had to be involved to support this, and they had strategies to engage not only staff but patients. And in summary, 80% of the studies reported some sort of favorable outcome, which is great. Like I said, a strength was that they included 2+ interventions, which I think, again, shows a commitment to systems and quality improvement. But there were some noted limitations. Basically, the heterogeneity of how definitions were applied for bloodstream infections, and different CQI methods were used. So it's hard to compare different studies to each other. So I'm going to now, kind of in the end here, summarize and go over a few of the studies that I thought were in particularly really enlightening, and I wanted to share with you. So there's 3 of them. So the first one was done a few years ago in 2013, and the intervention was multifactorial and basically implementing the core interventions from the CDC. So many different aspects to it, but a multi-pronged approach, including surveillance, including antiseptic care, audits of care, education and engagement with patients and providers, staff training, checklists, process measures, and a focus to reduce the catheters as well. And what we see over on the right-hand side are 2 graphs. The top graph, and I know it's super hard to read the little tiny print, but I will kind of go over it for you. So the top graph is showing that things look pretty level until they started these core interventions. And when they started the core interventions, bloodstream infections in entirety went down 32%. And bloodstream infections related to catheters went down by 54%. That's the bottom graph. Okay, so that's what that's showing, that jump down. And another study came back to this, looked at these sites and what they were doing 4 years later, and found that these benefits were sustained 4 years later. So implementing this comprehensive approach of systems and quality improvement, multifactorial, improved and optimized prevention. I wanted to highlight one of our nursing colleagues who led a study, Christine Bake, and talk about this article from the Nephrology Nursing Journal, just because I really appreciate how this journal structures their articles, and really it's kind of follows a nice systematic and QI approach as well. But Christine Bake did a multifactorial implementation, again, used root cause analysis, current future state mapping, protocols, teams, and took infections related to catheters down from 10 per year to 1. And then lastly, the last study I wanted to highlight, I think is a really amazing one and has been touched on as well in other areas of people talking today, but it's a retrospective study that Dr. Johansson led. And it was looking at whether or not during COVID, when we did all of that, putting on the PPE and extra hygiene and the goggles and the masks and everything, did that confer a benefit to bloodstream infections? And if so, was all that benefit due to all that extra stuff we did, or was it due to something else? So the graphs that are here, I'm going to kind of, oh good, I can use this. So on the top here, we see some dotted lines. So right here, this black dotted line is antibiotic administration, how much antibiotic they had to give in 2018. And then we go to 2020, and then we go to, 2019 is the red line, and 2020 is blue. So it went down from 2018 to November 2020, less antibiotics. And then they looked at admissions for catheter-associated bloodstream infections. Black is from 2018. The solid line, the solid red is 2019, 2020. So both antibiotic administration and admissions related to catheter-associated bloodstream infections did go down. However, when they delved into the data, some of it was due to these processes, and some of it was due to the trial that Dr. Locke had mentioned. It was a trial of ClearGuard versus Tego Curis, and the bottom line is, I'm not going to re-review it because Dr. Locke did a super excellent job on that, but this large dialysis corporation that did this study and published this data then rolled out this ClearGuard to all of their facilities, the better performing system, and that actually showed up as part of the reductions that were picked up in Dr. Johansson's study that I showed earlier. So there are some unexpected twists we might see when we're thinking about things from a systems or a quality improvement perspective. First of all, we know from some of the reviews that I mentioned, and I didn't get into the details, that some of the sites that had more catheters have experienced lower rates of infections. Not in all cases, but in some. So more catheters, more prevalent, less infections. But if you think about it, at least as a clinician perspective, I know that if I do procedures more frequently, I might have protocols in place or just feel more comfortable and potentially get less complications. So I don't know that it's counterintuitive, but it also maybe speaks to understanding what our problems really are when we're trying to address them. And also to me speaks to the ability of processes that are standardized and something we're used to, maybe potentially helping with lowering infection along with other things. And then the last point is that culture matters. So many years ago, kind of early 2000s, in the state of Michigan, there was a quality collaborative to improve infection rates in ICUs related to catheters. And a whole bunch of, again, multi-component quality improvement initiatives were packaged. It was called kind of the Michigan program, and it reduced infections in ICUs related to catheters. So some individuals from the UK took this package and put it into ICUs in the UK. And what they found is that improvements were seen, but it was not any more than what was seen in other ICUs that didn't put this into place. And Mary Dixon Woods did this study trying to explain why this occurred. And after interviewing staff, felt that a historical perspective that ICUs felt about what CQI is and how it was used or couched to people mattered, because sometimes there isn't a happy feeling about it because it's used as a code word for other stuff. And that a lack of success above secular trends was attributed in part to a top-down ownership of saying, do these things, instead of taking the approach of collaboration with the teams. So there wasn't as much ownership. So just in summary of considerations and opportunities looking ahead, I do feel that I've offered at least hopefully some reinforcement of some of the strategies that you can use. There's still obviously some work we have to do to understand the impact of these strategies on outcomes, but using systems and a CQI approach together, I think, along with recognizing a need to tailor it, can help us optimize care, not only related to infections, but in many other areas. These are the people that I'd like to thank, and I think I'd be happy to take questions, and I appreciate your time at the end of the day today.
Go ahead.
Thank you for a couple of great talks. One thing to remember when looking at study results is that there's studies. 18 months ago, I had an AAKP patient roundtable where I was talking with catheter patients who had had CLABSIs and some who had not. But uniformly, 13 out of the 14 patients, when I mentioned scrub the hub in the protocols, I got a horse laugh. And I said, why are you laughing? They said, look, these nurses are under such brutal time constraints. One of the patients said, I had to stop a nurse before she changed my catheter because she'd come from one patient to me and hadn't washed her hands. Mm-hmm. And I think the point is that in the real world out there, the instances of exposure of the catheter hub in the ICU and in the commercial environment are happening with much less adherence to the protocols, because the people who are being told do the protocol are on this get them in, get them on, get them out, mm-hmm. and have no way to follow those protocols effectively. Another point was that in trying to, your pictures show the hub and the connectors exposed. Good reasons for that. You don't want that thing to come loose and bleed. I was talking to a home dialysis nurse who related to me a patient who had 3 successive capnophagia sepsis events and did a home visit. And here's the patient with the exposed connectors, sitting back in her chair, asleep, cuddling her cat, who is licking the connector. Okay, so again, real world. Mm-hmm. Our patients are taught expose that connector so it can be seen, so it doesn't come loose, but that in and of itself, and then you've got the whole issue of sticky tape and gauze that some individuals are taught are the way to prevent these. So how do you take these results that were done in a laboratory setting, turn around and go from the bottom up and talk to the patients and see if they're being adhered to.
Yeah. I think that's really an excellent observation, and I really appreciate your comments. And, I'm a clinical trialist, and the best way to get rid of a disease entity such as CRBSI is to do a clinical trial. So, to your point, having these systems and processes in place, and in response to your comments, when you have a clinical trial, you get randomized to an intervention group plus the standard of care, and to make sure that the standard of care is adhered to, all of the proper processes that should be happening that weren't being done are reviewed during a trial setting. And the baseline rate of the infection goes down. And this is what happened in the methylene blue study. So they didn't actually find a great reduction because the event rate went down, because we know that the things, if you do them properly, actually work. Mm-hmm. So the question is, how do you get that to work? And I feel it really depends. Like in Canada, we have a different system of how to do things, but your comment, and I hear it all the time, of the machinery of having to get patients in and out, and the turnover is so quick, they just don't have the time. So I think, why is it then in a clinical trial it can happen? And I think it's the incentive. Right? So somehow, I can't fix the problem because I don't know the US system, but there needs to be incentives to be able to make sure that there's time for those processes to be done. Right? And I think a lot of it is pressure also from the patient because they don't want to stay there. So not only are the technicians and nurses having to push them through, the patients also want to have limited time on dialysis. So it's a two-way street, and that's where I think you have to give the patient, educate them, and they need to be engaged in their care to say, I need that time to be able to have that done properly. And your patients stopping that nurse, I think that was amazing that they did that, to say, hey, this is my catheter, this is my life and my lifeline, you need to take care of it, right? So I don't know, I don't know if you have comments on that.
No, I think you answered it in an excellent fashion, and it is frustrating to me to hear how things are in research in the real world, and it's particularly frustrating because I came from the real world. I mean, I worked as an engineer for 10 years doing systems work in the real world. They didn't care about publications. They were just trying to make money in the particular industry that I worked at, and it was consumer products and healthcare both. And so what I think it does come down to is culture, and the culture of rushing people through has got to change. I'm not going to pretend like, oh, yeah, we can make it work with that. You can't. So the culture change and the success, kind of the last study that I showed, is huge. And then I think the other part, the ownership, is on me now that I don't know if I'm not in the real world, but I'm working more in academics and I do research, and then I do some real world stuff with the quality improvement. Okay. But so what I'm trying to do is bridge that gap. And that's why when we do studies and trials, we need to do more on the implementation side. Implementation sciences, pragmatic trials. I know those are just fancy terms, but for me, it's like trying to make it work in the real world. And so that's the research that I'm going into now, but it's going to take years. And thank you for bringing these things up.
Just before I answer, you asked just one quick thing. I think the culture is key because, in the United States, there's that culture to move people through. Whereas just on Thursday, I got a call from the nurse. I can't get the patient to stay, so they want the patient. So it's the opposite. Yeah. And that's the culture in different facilities in different countries. Sure. We actually want them to stay for their whole treatment. Mm-hmm. Whereas in the US, because of the fee and the reimbursement structure, there's that push to move people around.
And right? We do want them to stay too in the US. But yeah.
No, they do, of course they do.
There's other pressures.
But there's other pressures that we don't have because of our payment system.
No, yeah.
And that is a reality, unfortunately.
Well, I think the systems are actually more similar than dissimilar. Mm-hmm. I know we always say it isn't. I've seen both. They're basically very similar. But it is culture, like you said, right? Mm-hmm. The reason the nurses feel pushed because or the techs, because that's what it is, they're looking at a different time clock. But as we teach them how to scrub the hub and do these things, we don't teach them the why. Mm-hmm. Not a single one of the techs love our patients. They don't want our patients sick. It's culture. It's them understanding the why, and it's worse, it's the doctors. Because we don't wash our hands when we come in the unit. We don't wash our hands between patients. We don't do the things we tell them to do. So where does that go? And then we go to CQI, and we were having this discussion,
Right.
we go to CQI, and we're not paying a damn bit of attention. So we have to drive that culture. And I love the whiteboard, the huddle board, because every day you walk into your unit, you should know your infection rate. You should know your catheter rate. And that's not time. And I used to work for Fresenius. I don't anymore. They're not evil empires. We just think they are. Everybody wants the best for their patients.
Yes.
But we don't teach the why. We teach the how, and I can't remember how, but I can remember why, which drives the how. So all your points are valid, but they're not. They're excuses, right? We have to get past excuses. This is about people's lives. And so we have to drive that. And yes, there's a study by psoriasis. And you guys, great talk. I just want to say I love both of them. Thank you.
Thank you very much. Thank you for